I'm Helen Smith. I'm a consultant clinical psychologist here at the London Spinal Cord Injury Centre, known as Stanmore. My plan for the talk today is to help you all understand a bit more about what it's like to have Cauda Equina syndrome, and then I always like to give people something positive to take away, so we're going to think about what helps. I myself don't have Cauda Equina syndrome, but I've worked here for 23 years, so I've seen a lot of patients. In case you're wondering what a clinical psychologist is, I'm not a doctor, not a medical doctor. I'm, I suppose, an applied scientist. We do a degree in the science of mind and behaviour, psychology, and then a clinical psychologist does a second degree to help apply the findings from research in those areas to people with problems, whether it's a neurological disability, whether it's mental health problems and other. And what I've noticed in all the years I've worked here is that the services have changed a lot, both within the NHS and outside. Now, my colleague Dr. Gavronsky sometimes refers to people with Cauda Equina having a constellation of issues, which might seem an odd word, but actually I think it's quite appropriate because there are a lot of issues that you might have, and different people have different ones, some or all of the following. The well recognised ones are the physical impairments, including bladder and bowel problems, sexual function issues, mobility of course, and falls. And often people with Cauda Equina syndrome have had negative experiences with the NHS and community services. Of course, some think about pursuing a legal claim, but I think we have another speaker talking about that very complex area. Now, some of the less well recognised aspects are the following. I noticed when I first met people with spinal cord injury who could walk that these were some of the most distressed patients that I was seeing, despite being seen as lucky because they could walk. It seems that what they were trying to do was maintain the roles that they used to fulfill, parenting, working, driving, things like that, and failing for various reasons. They were feeling guilty, they were feeling frustrated, a lot of conflicting emotions, like I'm grateful but I'm angry, I'm lucky but I'm misunderstood. And the upshot of all of this was a lot of them were very socially isolated. Now, back in 2011, I had a look to see if there was a literature, any relevant studies in this, and there was not much for me to go on. There were studies of surgical aspects, there were a few papers about physiotherapy and Cauda Equina, walking aids. There was definitely a lack of research into people's lived experience, and as far as I could tell, there were no groups running. There was one study done in 2012 by Jannings and Pryor. It's in a journal called Disability and Rehab, and that was helpful and relevant. It talked about people experiencing fatigue and frustration and having a lot of invisible issues. And it pointed out that people actually need professional and peer support, both before and after discharge. And it said especially so in the non-traumatic ambulant people, which is interesting because a lot of people with Cauda Equina, it's a non-trauma story. It's not a car accident or something like that. It's a gradual onset of pain and difficulties. So I started to think about offering a group for these people that I'd seen separately as outpatients. And I had an idea of two aims for the group. Peer support, as we call it, the support of comparable peers, people with similar neurological condition. Of course, their levels varied widely. And secondly, an educational aspect, so practical exchange of ideas, possibly some expert speakers. But I wanted the group to be very much their group, so although I had my suggestions, I wanted to hear their ideas and incorporate those. One of the early problems we had was what to call the group. Medical people tend to talk about ambulant spinal cord injury. Back up, the charity started using people with spinal cord injury able to walk. I think it was a great string of capital letters. One of my group members, Joe Robinson, coined the term ambuplegic, which some of you might have heard of. It's a combination of ambulant and paraplegic. And if you Google ambiplegic, his name will come up, and also below that something that I wrote comes up as well. In the end, we just settled for walkers group, which is blunt but kind of works, because the people in my group, some have Cauda Equina, some have higher level spinal cord injury but incomplete, so they all have some ability to walk, although some will come with their wheelchair sometimes, and many with walking aids. So in the early meetings of my walkers group, we had a mixture of external speakers, for example, doctors from the hospital, experts in bladder and bowel, pain management, that kind of thing. Some were internal, members of the group themselves with knowledge to share. There's a picture of me and some of the group members with our hands in the air. We're doing Qigong, seated Qigong, which is a bit like Tai Chi. It's kind of good for body and soul. I think we were being trees or something in that picture. But one of the members of the group was a qualified Qigong instructor, and he ran a session for us twice. We also had a researcher from Loughborough University, and out of him meeting my group and taking some conversations forward, they developed a book, which I hope some of you will have seen, bright yellow cover. It's called The Very Alternative Guide to Spinal Cord Injury by Anthony and Joe. And they used my group to discuss some of the drafts, look at some of the layouts. Joe is an artist and came up with these colourful pages to illustrate points. So that was a more active group discussion. We also did some social meetings off the unit, and we built up links with the relevant charities over the early years. Initially, I had members fill out evaluation sheets at the end of meetings, and the ratings tended to be good. The group considered it enjoyable, helpful, and the opportunity to be with others who have a similar condition was considered beneficial. But by about 2015, I was thinking perhaps it's time for some more objective research. Now, I was lucky to get a medical student called Lara Shemtob from UCL to come and do my evaluation study for me. It was good to have an external person, not have me asking my own members what they thought of my group. Now, she did a literature search and a pilot study with some measures, some qualitative questions, and the names were picked from a hat. So in the pilot study we had 3 members, and it was useful because it showed that the standardised measures we had chosen were not ideal for the purpose. They showed that post-traumatic growth and depression and pain were experienced, but the items were confounded by other issues such as fatigue. The qualitative questions, on the other hand, drew good responses and reflected issues important to the members. So, we continued to the main study. Lara designed some Likert scales to capture the impact on mood, pain management, how well informed people felt about their injury, and how well supported they felt by the other members. She did some semi-structured interviews, which were audio recorded and transcribed and then analysed to draw out key themes and sub-themes, and my colleague Dr. Carol Smythe did that analysis. 8 participants were identified, 6 attended. We had no external funding, so we were limited by Lara's time, my patient's time, and room availability, the realities of the NHS. Now, I've included a slide about the findings. It's a bit overly detailed, but in essence, we had 6 participants, 3 of whom had Cauda Equina, and that's representative. The group is roughly half at any time, people with Cauda Equina syndrome. They had different ages, different times since injury, and different numbers of group sessions attended. So the results of our study, the 6 subjects, they had different demographic details and different levels and causes of spinal cord injury, but they all reported improvements in their mood, in their ability to manage pain, in how informed they felt, and in how supported they felt since attending the group. Moving on to the qualitative results, so the findings from the semi-structured interviews, the first theme that Carol drew out was, no surprises, physical impact. Problems with walking, with balance, bladder, bowel, sexual function, and pain. And a couple of quotations from the members. One of them said, "I don't like walking. It's a lot of effort. It's uncomfortable and I often fall." Another person said, "The bowels are the most problematic. It's life-limiting through my fear of going out and having accidents." Theme 2, psychological impact. So feelings included depression, emasculation, anxiety and stress, defensiveness as in always having to justify yourself, and the constant struggle trying to stay walking despite the effort. One person said, "I still get down thinking, why me?" Another person said, "It affects my quality of life, but I try to be positive." Another one said, "On a good day, I really push myself, but I suffer afterwards from the overexertion and then more is expected of me." So perceptions of walkers by other people. When there's a hidden disability, people make assumptions. There's jealousy, as in wheelchair users envying people who can walk. There can be prejudice and judgment, including being judged by able-bodied people in their own family. One person said, "I would trade straight away, take away the bladder, bowel and sexual function issues, and I would lose my ability to walk," which is a pretty strong statement, isn't it? Another said, "My disability benefit was declined because I could walk until I showed her my catheter equipment." That's quite shocking, isn't it? The degradation that people sometimes have to go through with this condition. Theme number 4 was the walker's perception of wheelchair users. They talked about feeling guilty. They also had empathy and understanding for those less mobile. Many of them had been there themselves. But they did point out that wheelchair users can get priority sometimes for sympathy and for help. One of them said, "I feel thankful that I have more mobility, but I can empathise with what everyone goes through." Theme number 5 was about the group. Huge benefit was reported by most of the members. They said things like, "Everyone thinks the same as me, it's amazing, the problems are more manageable." There was openness, being yourself, sharing the same problems, being able to talk about bladder catheters and things like that, where you can't do that with anyone else. They felt they learned from others and shared knowledge. They said there was a feeling of brotherhood. Everyone had been through hell. Some members keep in touch by email and phone after meetings. And there was a comment that the group was unique. They said, "Helen has created something that would be difficult to replicate." Another person said, "When you see people struggling, it makes you feel better and think, I'm probably not doing that badly." Another person said, "I spend a lot of time pretending I'm way less disabled than I am, portraying myself as strong and capable, but I feel safe in the group." The conclusion of our group study was that although participants could walk, this was often limited and effortful, with many hidden problems not understood or acknowledged by the general population, and this in turn had far-reaching psychological ramifications. Secondly, of course, not everyone would suit a group or would want to come to a group, but the regulars did feel better informed to manage their unique challenges. They felt better in mood and supported by others who understand. The charity Backup did a survey of their membership with a view to walkers' opinions, and their presentation in 2016 talked about much the same themes. People having feelings of guilt and lack of entitlement, people feeling excluded from the spinal cord injury community because they could walk, and the stigma around using a wheelchair. Now, there was a nice study published in Spinal Cord in 2018. This was Rosie Hall and Kevin Jones. Rosie was a trainee psychologist who contacted me to ask if I could help her recruit some people with Cauda Equina for her study. So she included some of our patients, and they were looking at the lived experience of Cauda Equina syndrome. They interviewed 11 people. They used the same type of thematic analysis, and they did well getting it published in Spinal Cord, a major journal. The themes that they report, there were 3 themes. One is the dissatisfaction with care. "I felt very abandoned," is the quote that they gave with that one. The second theme was feeling hidden to others. Nobody knows, it's horrible. And the third was changed identities. You become someone totally different. So I imagine some of our listeners today can relate to those. I had a look for recent studies and I found one 2021 in something called Plos by Hazelwood and others in Edinburgh. This is more of a medical study, but they were looking at long-term mental well-being and functioning after surgery for Cauda Equina syndrome. They had 46 people took part who'd had their surgery back in 2013 to 14. They completed their measures via a telephone interview, and what they found was that there was an increased risk for depression, especially where there was bladder and bowel dysfunction. And I think that conclusion is right. From my clinical experience, it's often the bladder and bowel thing that gets people the most. So if we think about the current context, Stanmore has a walkers group and we have our own Cauda Equina syndrome pathway now. Claire Thornber has a thriving charity with online presence and support groups nationally. Backup have special courses for people who can walk and a mentoring scheme. And the other charities have also started representing ambiplegic people better. Invisible disability is better recognised now. Now, I've included a photograph of a sign on a door, and I hope most of you will be familiar with these because they're coming more commonplace across the nation. It says, "Not all disabilities are visible." I took this photo in a museum in St Albans a few years ago, but I've seen the same kind of sign in airports and supermarkets. There's a second photograph here which I took in my local Sainsbury's a couple of years ago. It says, "Help for hidden disabilities. Ask us about the sunflower lanyard." And there is now an organisation and a website about sunflower cards, sunflower badges, if you want help with your hidden disability. However, I think it's fair to say that there are people in government and in society who are prejudiced against people with disability, and there is some evidence for increase in that prejudice. There's a book by Frances Ryan, a journalist with a disability herself, quite a depressing book actually, I couldn't finish it, where she talks about how successive government policies have made it harder and harder for people with disability to manage financially and in terms of their independence. So what helps? Certainly listening to a person with Cauda Equina syndrome is a powerful tool. If you're working with or living with somebody with Cauda Equina, do listen, it's worth it. Expect some anxiety and frustration, that's always a big one. Ask them perhaps which role is concerning them the most. Add to their strengths and their knowledge and their coping tools and tell them what has helped other people. I like the idea of a coping toolkit because there are lots of options and the person can't fail. It's not that you're coping or not coping, it's which tools are you using today and how can you add to them and become more practiced at using them. One important tool is the ability to develop and rehearse some lines to use when people stare at you or ask awkward questions. And I mentioned if you Google ambiplegic and scroll down, you'll see an article I wrote for Claire Thornber's blog a few years ago, which is about dealing with other people not understanding your disability and preparing to answer their questions in calm and effective ways. Now, we'll talk briefly about pain management because pain is a big part of life, sadly, for people with Cauda Equina syndrome. There are many tools that you can add to your toolkit. Pacing and mindfulness are quite well known. Breathing and relaxation techniques are good basic starters, and there are apps to help with those. CBT or cognitive behavioural therapy may have a place in the decatastrophizing, if you've heard of that, but often it's not the most appropriate because people's thoughts about their life are often not overly negative, they're actually realistic. Distraction, of course, is important in pain management, but I understand that with severe neuropathic pain, it really is a huge challenge. There's a nice book about managing pain after spinal cord injury from Australia. It's called The Spinal Cord Injury Pain Book by Siddle et al. I've added a photo in case people want to track that book down. I would recommend it. Lots of practical advice in there. Now, behavioural activation is a term that many of you may not have heard of. It's my favourite type of psychological therapy for this group. It's about encouraging a person to structure their time. If you think about your week, having structure to your week, like a timetable, with activities spread through the week, and if possible include activities that give you a sense of achievement, as well as social activities and some fun or relaxation. Sounds like common sense, but actually when you look at your week, you may be missing out on one or all of those because of the Cauda Equina or its impact on your income and your social life. Now, you're going to need to set small goals to increase your activity, and you'll need lots of encouragement, praise for your ideas and your efforts. Now, sometimes when I suggest to people that they increase these activities, they say, "But Helen, I can't go to the West End anymore." And I say, I don't go to the West End, that would be an enormous goal for social activity. I'm talking about really small things like invite your neighbour around for a cup of tea, or make a phone call to a friend that you haven't spoken to in ages. That would increase your social contact, but in a small, easy and affordable way. You can always build up to the bigger ones. For achievement, it may be that you had a really high-flying and busy lifestyle, but you might now need to think about breaking things down into very small goals. So it might be, I've got to do my tax return, it's overwhelming. My first goal will just be to get the box files out and put them on the table and clear a bit of space and then come back to it tomorrow. Another one could be just sorting out your cupboard one shelf at a time. Another therapy that you might not have heard of is acceptance and commitment therapy, or ACT. This is good for pain management and for stress, the stress of having Cauda Equina. It has a mix of mindfulness, thought diffusion techniques, which is a bit different from CBT, and you make a commitment to actions based on your values. It makes you think about what is really important to me, rather than wasting time on things that are not so important. There's a book called The Happiness Trap, which is not new, so it's cheap online, and there are online resources to go with it. So I'd recommend have a look at those. The final psychological therapy that I wanted to tell you about is called compassion-focused therapy. Do you have a harsh inner critic? Do you talk to yourself in a critical, hard voice? Most people say yes when I ask them that, unfortunately. Now, it's possible to train yourself in a habit of being more compassionate or even neutral with yourself, but it takes time and practice. I've been working on this myself and I'm not there yet. But it is valuable for preventing depression. And for anybody with Cauda Equina syndrome, we know that you have a heavy burden to carry, and being kind to yourself can be the thing that makes the difference. For those of you who want to look at some further reading, I've put some of the books and references that I've mentioned onto the slides. But I'm just going to leave you with some final messages. To any healthcare professionals listening, when you see people with Cauda Equina syndrome, don't assume that they'll have depression. Assume that they are actually resilient, but you may need to address their really frustrating reality. It maybe help them to obtain benefits, it maybe help them with equipment, but once the frustrations are addressed, the resilience comes through. Do encourage them to be active with small goals and coping tools, and do encourage them to be kind to themselves. And for those of you who are living with Cauda Equina syndrome and your relatives, I would say do engage with other people who have similar experiences. It does make a difference. And you might want to offer your support to them when the time is right. And that engaging with other people and helping them might just give you that sense of achievement that we talked about that might have been missing, and some social contact, perhaps even some fun. Thank you.